Good afternoon, everyone, and welcome to the Agilus Medication. The topic today is on critical callouts. Critical callouts, as you're all aware, are very, very important. Communication of abnormal result to the treating clinician needs to be done when an intervention is required and the values are critically low or high. As they say, a report delayed is a report denied. So to take us through this very important topic, we have Dr. Ravneet with us today. Dr. Ravneet is lab head of the Agilus lab at Fortis Hospital, Noida, and she's also a senior microbiologist. Ravneet has 19 years of experience, and it is our privilege that the past 14 years have been with Agilus Diagnostics. Her areas of interest include bacteriology and hospital infection control. She has taken additional training in ISO 15189 and also is an internal assessor for NABH. Dr. Ravneet has numerous publications to her credit, and she is also a member of NAT Health. NAT Health is the Healthcare Federation of India, a body which works with public and private sector and provides input to the Indian government for formulating correct antibiotic policies. So welcome, Dr. Ravneet, and we are looking forward to your presentation on critical callouts.
Thank you, ma'am. So I'll start with my presentation. Is my presentation visible and am I audible?
Yes, both are perfect.
Okay. So good morning, everyone. So today I'm going to cover a very important topic as regards the lab aspect is concerned. This is about the critical alerts and the importance. Just 1 minute, please.
Take your time. As always, any questions, queries, comments can be put on the chat box, and at the end of the session, we will address them.
So coming to the background first, as Madam has already told, critical alert is any lab value which may require rapid clinical intervention to avert significant morbidity or mortality. Also, it is of paramount importance that any critical alert value be intimated immediately to the concerned clinical team to allow the rapid clinical intervention. Now, covering the background again, these critical values are defined section-wise in any lab by the section in charges. In hospital labs, these values are defined after discussion with the concerned clinician teams. The SOP on critical alert policy must be reviewed at least annually and as and when required on clinician request. Now, what do the recommendations say? As defined by ISO 15189-2012, interval of examination results for an alert or a critical test that indicates an immediate risk to the patient of injury or death. NABL 112 says that the laboratory shall establish and display critical limits for tests which require immediate attention for patient management. Test results within the critical limits shall be communicated to the concerned clinician after proper documentation. Now, we have got the new version of ISO 15189-2022. This is more elaborate on the critical alerts. This says that the user or the authorized person is notified as soon as the results are based on the clinical information are available. Actions taken are documented, including date, time, response, the person to whom it is notified, the results conveyed, the verification of the accuracy, the information, and any difficulties encountered in the notification. The ISO 15189-2022 also says that lab shall have an escalation procedure for lab personnel when a responsible person cannot be contacted. So basically, it says that when lab is trying to notify a critical result to the nominated person and that person cannot be contacted on phone or an official mail, then lab shall have an additional escalation procedure. Now, important thing is that the Agilus critical log addresses all these points, that to whom the value was informed, what was the test result which was informed, what was the date, time, and the person who notified and person who took the call. So what does NABH say about the critical alerts? So basically, chapter 1 of NABH, which is AAC, that is Access, Assessment and Continuity of Care, there's a standard 6 on entire lab services. And in the standard 6, we have commitment level standard G, which addresses this point of critical alerts. It says that critical results are intimated to the person concerned at the earliest. It also says that lab shall establish its biological reference range for different tests, shall establish and document critical results for tests which require immediate attention for patient management, and same shall be documented duly. It also says that if it is not practical to establish the biological reference range for any test, the published literature will be referred to for defining the same. Now, again, what does the NABH says? NABH also says that critical results of outsourced investigations are also included. So basically, if any lab is not doing any test in-house, it is outsourcing the test, even then the lab is responsible that the concerned clinical team should be informed about any critical values. There should be suitable personnel who are identified by lab in charge to report the critical results. And results shall also be communicated to the person from the treating team, whether it is doctor or doctor member of treating team or whether a ward nurse, at earliest but not later than 1 hour of completion of test or report being ready. However, it is preferable that the primary clinician is informed in case of any critical results. Again, coming to NABH only, it also says that the intimation shall include name of the patient, UHID, which is a unique identification number in a hospital, date and time of sample collection, test name, result, measure unit, reference range, operator identity who has communicated, identity of the recipient, readback and date and time of acknowledgement. This readback is very, very important, and it is also checked by majority of the NABL as well as NABH auditors. So basically, since the value which you are informing is a critical result basis which the patient management can change, so the person who is calling, who's notifying the other person about the critical value, he will also ask the recipient to read back the entire result, that, sir, can you please repeat what I have just said? For example, if you are informing the other person of any sodium value or any potassium value, so you will ask the other person who is taking your call to read back the entire value. So this intimation shall also be duly documented in your log. In case of electronic health systems, the system-generated critical result reporting can supplement the physical reporting of critical results. However, all the above points, that is name of patient, UID, date and time of sample collection, should be available in the system-generated log also. Now, how do we define the parameters included in the critical alert list? This is a very important aspect. The parameters have to be defined by the respective section doctors because they are the ones who are dealing with the results in and out on a daily basis, and they are the ones who are aware that the following value can be critical in their section. So generally, any parameter which is abnormally high, abnormally low, or out of reference range, or may require immediate clinical intervention, these parameters are included. As I have already said, the list has to be defined and available section-wise. For example, Pathology, hematology, clinical batch, serology, microbiology, all these sections will have got their own critical values available section wise, which the staff should be aware of. Once the list has been finalized, this list has to be controlled according to your own SOP, whether internally controlled or if you have a central QA department externally controlled, it depends on your own SOP. It should be displayed in each section for the reference of technical staff. Now, another important thing and which is very relevant practically is that one parameter may be critical for a certain specialty, but acceptable for another one. For example, creatinine in nephrology. This is one parameter which usually the nephrology team says that for example, we do not want to be informed of any creatinine which is higher or lower than this particular value because majority of their patients will fall in that bracket. But the same creatinine value may be of importance in certain other patients. Hence, it is very important that whenever you are defining your critical alert values, you also discuss with your clinicians. It is something which is mandatory and you ask for their opinion, and according to their opinion only this list should get finalized. In our labs, these values also show on our system, on our CLIMS with a flagging of low or high. This is applicable for all the digital values, but this is not applicable in the manual ones which are typed manually. For example, if you are seeing anything abnormal in a histopathology lab, then this will not show as a flagging because it is a typed value. Then coming again to the examples of critical alerts. So basically any electrolyte or sugar or creatinine above or below a certain range or highly abnormal can be the example of your critical alert. If you are seeing malignant cells in a fluid, if you are seeing a growth in a sterile fluid, for example, blood culture is showing gram-negative bacilli, for example, pleural fluid is showing budding yeast cells, or some similar sterile fluid is showing some growth. So all these will go into your critical value list. Besides these parameters, it again depends what is defined. So basically anything which a lab doctor feels this should be escalated, this can be critical, so you should not think twice about it. Even if it is not defined in your critical list at that time, you can certainly make a call to the clinician at that time so that it is not missed. Now, how do we define critical alerts in a standalone lab that is a non-hospital based lab? So the defined critical alerts list section wise should be available in a controlled manner. This list should be displayed in various sections. This list is annually approved, at least annually approved by the lab head or the director. Call out is made at the number which is provided in the system, whether that number belongs to the doctor, patient or client, and this is documented. Plus, in our labs, auto SMS also goes at the number which is provided in system in our labs. What happens in new labs? Generally, in our newly opened labs, the alert SMS goes as per the instrument reference ranges, whether they are high or low, till the time the lab defines its own critical list and feeds it into the system. Now, what happens in case of critical alerts in a hospital-based lab? The results are communicated to the person from the treating team, whether it is a doctor, doctor member of treating team, or a ward nurse. It is very important to note that in the NABH audits, generally the auditing team checks in the patient files at what was the action taken basis the critical alert from the lab and whether it was documented in the file after the call came from lab. And generally, the auditing team does a retrospective audit starting from the patient areas, noting down the patient details. Then it comes to the lab and it matches the alert that what was written in the file and what was written in the lab record. Hence, it is very, very important that the critical alert is duly done, it is duly documented in a correct manner. Now, coming to another important point that how to inform a critical alert. So the identified section staff fill the critical alert log sheet very carefully, filling all the columns. This sheet should be filled immediately after the report is finalized. From this sheet, the identified lab staff Basically, the lab will identify the staff, that these staff will inform the critical values to the clinician team. The identified lab can be customer care group or the lab doctor or your technical staff. They inform the concerned clinician team about the parameter. After information, the read back policy, as I have already told you, should be followed. Call should be made in a clear and calm manner. After the log is duly filled, the concerned section doctors need to sign in each log. This is very important because this allows you to verify your own data at the end of day. So basically, the doctors will also come to know whether any column is not filled or whether any other thing needs to convey to the recipient or whether any other thing needs to be conveyed to the staff who are calling the clinicians. So coming to the OPD patients in a hospital-based lab, in OPD patients, we generally call both the prescribing clinician as well as the patients about the critical value. However, the value itself need not be informed to the patient to avoid panic. Because, for example, if you are telling patient something, one thing is that it is very unlikely that he will not understand completely what you are trying to convey to him. Plus, he can get panicky also. And there are chances that it becomes a little unpleasant. So, he can just be told that you please consult your doctor regarding this particular test. On rare occasions, when in a walk-in patients, we do not have the number of clinician or the patient in the system, then generally what we do is that we put a mail to the registration desk and to the hospital administration department and we document the same. So what is SMS Auto Alert? This facility is available in our system. So our labs have a policy that an auto SMS goes to the clinician in critical alert parameters. For this, the system should capture the clinician number. The latest list should be tagged in the system via ID. Now, this is again not applicable in the purely manual entries like the histopathology entries. But an important thing is that if the clinician number is switched off or not reachable at that time, then the message will not go. A summary of these auto SMS can be pulled out from the system. So how to go to SMS Auto Alert summary in our claims? So basically you open the claims, then you go to the report section, you go to the more column and then you go to the critical SMS send out report. Then you will put you will select the date range when it is required. For example, you need to see the data from this state and to this state. Then you will click at the I option in the claims and then the summary will show you like this. It is available both in PDF as well as in Excel format. So here I am showing you what the summary looks like. We have modified the UHID, the accession number, the name of the doctor, mobile number, because this data is confidential. So it will basically show you the accession number, the patient ID, that is a unique identification number, then the patient name, then the doctor's name to whom the SMS is going, the mobile number of the doctor, the element code, for example, swine influenza or dengue, the element name, the date, and the time on which the auto SMS was sent, SMS, the status of the SMS, whether it was forwarded or it was failure. What was the result? Whether it was detected on or not detected or some digital value, and in the SMS type it will show as doctor. Again, the important thing is that the doctor's number, the mobile number should be mapped correctly in the system. And if it at that particular time, because this message is sent immediately after the report gets finalized, if the number is switched off or not available at that time, then it will not go to the doctor. So this is a very good system this is a very good system. But then since it is an auto system, there can be some challenges like I already told you. So what we feel and what we are doing is that in addition to this system, we are also calling the clinical teams at that time to inform them of critical values. So what happens and what is happening in our lab additionally for infectious parameters? So basically for infectious parameters, which are also part of notifiable diseases as defined by the state authorities, we are sending an auto mail to the hospital authorities, in which we have covered the various mail IDs of medical administration, the medical records department, the nursing head, etc. What happens is that post release of any parameter, an auto mail goes to all these people like in this manner. As you can see here, the patient name is there, accession number, the UID number, then the accession date, the test code, the parameter name, the result value, report date, and biological reference interval. So in all the infectious notifiable diseases, whether it is dengue, whether it is COVID, whether it is swine flu, or leptospira or chikungunya, we have enabled this option. So again, this is a very good backup option which we have there in our system. So this is just to show you how our critical log sheet looks like. So this is a centrally issued log sheet by our QA department, which is very comprehensive and it covers all the aspects of critical log sheet which it should have. So there is an option to write the serial number, the accession number, the parameter which is being informed by whom and informed to whom, the contact number of the person, date and time of call out, and whether any difficulty was encountered. This last column, I would say this is last but not the least. This is a very, very important column. If there is some difficulty encountered, the staff who is notifying should write here. This is very important for the safety of the labs and as well as to handle any challenges which are being occurring on a regular basis. So you also have to write the examination results which were conveyed, an examination result confirmed by the readback policy. And in the last, there is a column where the section head is supposed to sign. So just to show you our own parameter-wise critical alert list, this is our own list, and all labs should be making their own list, as I already said, basis the clinician opinion. So we have a section-wise list. For example, we have in the hematology, we have defined what should be the WBC, what should be the hemoglobin, platelet count, APTT, D-dimer. In biochemistry, again, we have got different values of serum calcium, glucose, and there are certain values which would be differing in the pediatric population, which would be differing in a nephrology patients or liver transplant patients. So this is a very customized list which will vary from lab to lab and from hospital to hospital. So again, coming to the list, this is a list of clinical pathology. Then in microbiology, we are supposed to inform the gram stain of positive blood cultures, the culture positives of any sterile fluids, whether it is a positive hanging top preparation. So basically any value where you feel or where the clinician feels that this is very important for me and I need to be informed about this at real time basis only. So it doesn't matter when the result is becoming finalized. Since we are working in 24-hour labs, at whatever time you are getting this value, it should be informed real time to the clinical teams. So we have got serology list and we have got the histopathology list. We have also added a note here that anything unusual or rare, if the doctors feel that this should be informed by the lab staff, we will, although it is not written here, we can always call the clinician team at that time. So again, as I told you, for the common notifiable diseases sent to reference lab, notifiable mail alerts are sent to various departments. So coming to very important point, that what are the challenges in critical alerts which our team or which we face on a daily basis. So what happens is that many clinicians these days, they prefer getting messages on WhatsApp, whether it is a personal message. And now we have got the various WhatsApp groups. For example, we have got a separate WhatsApp group with the oncology team, with the nephrology team, with the internal medicine team. So the clinicians prefer that the messages sent on these group messages rather than I be called at that particular time, because sometimes it becomes difficult for them to take each and every personal call. And they are of opinion that since the people who are doing shift duties are there in the groups, then they can always see the message. But what is the acceptability of this in the court of law, supposing something gets challenged later on? So we have been discussing this internally, but as yet this is not concluded. This is still under discussion. Secondly, the need for information about the same parameter when repeatedly samples are sent. For example, if it is a dengue patient being admitted in the hospital repeatedly, daily, or even 3 to 4 times in a day, we are getting CBC values which are abnormal. So whether the clinician should be called the first time only, or whether every time you are getting an abnormal value, the clinician should be informed again and again. So this, I feel that this policy can be locally defined in concordance with that particular clinician or administration. But the important thing is that any such change which you are doing, it should be duly documented. Either you can record it in a register and the sign of the particular clinician be taken, or you can send it in an official mail and you can keep the copy of the mail in your records. So what I would just like to tell you what is new in our hospital system. So now we are supposed to monitor the time duration between the report finalization and when the call out was made, and it should be within 10 minutes. And this is supposed to be monitored by lab. This data is shared on a monthly basis with our medical administration, and they keep a check over it. This data is to be entered on a dashboard which is provided by the hospital system monthly by the laboratories. And if there are any outliers, for example, if any result it was not informed within 10 minutes, we are also supposed to write the reason why it was not done. So I feel this is a very good system because at least since it is a critical value, then it is being informed real time to the clinician team. So something to remember is that something which is not documented, in you can assume that it is not done because you have got no record of it. And supposing it gets challenged legally later on, or supposing it gets audited, the people will not consider that it was done also. Hence, correct and timely documentation is of utmost importance. A good practice which many labs are following these days, direct call by the reporting doctor to the clinician. This not only ensures the timely alert but also helps a lot in building up a rapport with the clinical teams. And this practice will also allow you to get a compliance on the 2 quality indicators of lab which are required, that is clinician connect documentation and the lab advisory sheet. Because once you have a discussion with the clinician, you might have a further discussion that what else can be done in patient, and this will be good for the patient as well as for our documentation also. So last but definitely not the least, there are medico-legal implications if there is failure to inform a critical alert in a timely manner and if you are not documenting it. Because this may result in delay or failure of the required clinical intervention. At the same time, if there is a correct and due documentation, it can save labs from a lot of trouble later on. That's all. Thank you.
Thank you, Dr. Ravneet. You covered the topic very comprehensively, going from the importance of critical alerts to how to define them, to what our accreditation bodies, NABL and NABH, have to say about them. And you also covered how to communicate critical alerts, both for an IPD as well as an OPD patient. We went over technology and how technology can be used to communicate critical alerts and also how to monitor critical alerts. Thank you for an excellent presentation.
Thank you, ma'am.